Welcome to the SJMC Grand Rounds, where our experts come together and discuss challenging cases. Witness a synergy of intellect and medical expertise as we embark on our continuing medical education journey together. Before we start, I would like to remind you to subscribe to our channel and enable notifications so as not to miss our upcoming episodes. Now let's begin.
Welcome everyone once again to our SJMC Grand Rounds, and this is Grand Rounds number 30, and with us is our esteemed cardiology team chaired by Dr. Jayamala, with Dr. Ko Kok Wei, and Dr. Mohammad Nasrul. Hi. Okay. So just very quick housekeeping slides. As usual, we want any questions and comments via slido.com, and you can visit slido.com in your browser and enter 2881395 or scan this code in your phone to get the exact Slido Q&A. But if you're watching it in the DOPS website, the Slido is embedded there. Okay, so the Q&A will be only after the presentations. The link to register for CBD points will be presented at the end of the session. Okay, so without further ado, I'll pass over to Dr. Jayamala for her presentation.
Thank you very much, Alan. As Alan mentioned, this is our 30th simple ECG interpretation part 2. And with me, I have Dr. Ko Kok Wei and Dr. Mohammad Nasrul. Okay, the first stage will be presented by Dr. Mohammad Nasrul. Over to you, Nasrul.
Thank you, Dr. Jaya. Okay, so we're going to start off with a case of a very young lady. She's 26 years old. She had no known medical illness prior to this. She actually presented with epigastric pain, and she sought treatment at her family clinic. The pains had actually resolved with gastric medicines and she felt much better. But during her visit, she actually had an ECG done and she was told that the findings were abnormal. So she came over to the clinic for further clarification. On further examination, she was normal. As you can see, her blood pressure was 112/80. She had a heart rate of 70 and it was of regular rhythm. Yeah. Next. Well, I probably would not have done an ECG for her, considering that she's very young. She doesn't have much risk factors. But of course, if we do see a patient coming with epigastric pain, if they have got risk factors, advanced age, diabetes, I would consider doing an ECG because patients with an acute coronary syndrome sometimes can present with epigastric pain.
Good case. So I think whenever we order a ECG rhythm or any electrocardiogram by Holter's monitoring, you need to know what you're looking for. So great point. So when you order ECG, you need to know what you're looking for. Like for this patient, perhaps cases that I've seen, maybe they think that the pain relates more retrospectively, so they are very about chest, dissection, coronary artery dissection. So then we look for ST changes. Now in this ECG, we look closely. There is no significant ST changes also. So these are V2, V3, a bit of elevated ST segment are quite normal. Sometimes we call it early utilization. In young people with chest pain, we look for pericarditis changes, concave ST elevation. We don't see anything here. And when we look closely to the PR interval, it seems to be a bit long, about 200 milliseconds. So probably this is a normal sinus breathing ECG.
So what will you do next?
Yeah. To be honest, I don't like the name of the first rehabilitation because we imply pathology. Usually, I just say basically, doesn't correlate with the symptoms, so nothing. So just reassurance, maybe treat her with gastric medications and ask her to come back if there is any further problem. A lot of times, in general, first degree AD block or PR interval of 200 to 300 milliseconds does not warrant any treatment because most of the time they are not associated with symptoms. The only exception is when the PR interval is very prolonged, like more than 300 milliseconds, and associated with something like a pacemaker syndrome, where the atrial contract against the closed valve, then your patient will feel uncomfortable. That may warrant some form of treatment.
The patient is much older. I mean, this lady is only 20, so you can say, okay, or the patient is on a beta blocker. Is the management going to be any?
Again, no difference. Again, across the age group, first degree AV block doesn't warrant any treatment, or I'm not alarmed by all these things unless patient is very symptomatic.
I like the word that you said, prolonged PR interval rather than first degree, because sometimes I report ECGs as prolonged PR interval rather than first degree heart block. So I'm happy to know about one. Okay, second case. Going on to Nazrul again.
So this is also a young lady, 24 years old. She had come to the clinic with complaints of palpitations. She recently had changed her job and she was undergoing a lot of stress. She had a normal menstrual cycle. There was no evidence of hyperthyroid symptoms. So she had actually gone to a GP initially. She had done a few blood tests. Thyroid functions were normal, hemoglobin levels were normal, but the symptoms kept recurring, and that actually troubled her. So she came over to the clinic. Upon physical examination, her blood pressure was normal, but she was slightly tachycardic at a heart rate of 100, and it was of regular rhythm.
This is the ECG. So ECG show again.
I think for this case, it's more reasonable to order ECG because the symptoms was palpitation. So again, before you order a test, in your mind, you roughly need to know the differential diagnosis when you order ECG for this particular case. Like for palpitation, you expect things like premature ventricular complexes or premature atrial complexes. You expect something like atrial fibrillation, especially in the elderly patient. So you're not expecting any ST changes in this case. So if I look at these ECG changes, you can see that the striking features were strikingly normal, ST segment normal, no the very regular RR interval, I would say, but the rate is a bit on the high side, probably about 100 beats per minute. And all these QRS complexes, importantly, preceded by a P wave. So this is probably a sinus rhythm or even sinus tachycardia at a rate of 100 beats per minute without any other associated abnormalities.
Thanks.
So I think you have ordered the blood test, the two important blood tests you have stated, the thyroid function test and the hemoglobin, especially in young ladies, sometimes they have anemia, especially patient presented with menorrhagia. So both are normal. So if both are normal, sometimes I will probably just reassure again because you mentioned, Nazrul, that she's a bit stressed out. So I will put on an observation, or sometimes patients have a smartwatch. Nowadays, I think a lot of patients have smartwatches. They can monitor their heart rate. Or if the patient is really that anxious and you might want, she wants something to be done, then perhaps you might want to order something like a 24-hour or even more longer whole term monitoring so that you can monitor the rhythm.
I guess Nazrul, this lady wanted a Holter, so.
Okay. So again, I think when we order something, again, emphasize you need to know what you're looking for. We are looking for palpitation. So any ectopic beats, ventricular ectopic, atrial ectopic will be significant. Any paroxysmal supraventricular tachycardia, paroxysmal atrial fibrillation will be significant. Now, this, if you look at it, is more of a bradycardic episode. This will be significant if the patient has symptoms like giddiness or syncope. Now, I'd like to emphasize for the first two cases, the symptom rhythm correlation is very important. If you look at this rhythm, first of all, you have to look at the timing. Now, what is the time for this trip? It is 3 a.m. in the morning. Then you probably ask the patient, what are you doing 3 a.m. in the morning? Usually sleeping. Now, if you have a patient who is resting, sleeping, and you see again, you can see the P wave, the first strip, P wave, QRS, P wave, QRS, the second strip, you notice that the PR slightly prolonged. And then there is a P wave not followed by any QRS complex. And then the next P wave is followed by a QRS complex with a normal PR interval. So what is this, guys? So I think many of you can guess it correctly. It's a Wenckebach AV block, or also known as a Morbitz type 1 AV block. Now, a Morbitz type 1 AV block, it seems like the pathology is almost seems like, or I would say the mechanism almost seems like the first degree AV block. The problem lies on the AV node, where the AV node is resting and then it stopped conducting, and then later on it resumed back normally. And this is much physiological in most people, especially in young people, patients sleeping. And sometimes you can see this in a very fit athlete, even at resting awake, and they don't feel symptoms at all. So this doesn't warrant any treatment. In fact, it's quite common to see this once you start ordering a lot of Holter. So I would not be alarmed. I would say that this is a normal physiological Wenckebach AV block at night, sleeping. And I don't see any reason that can cause her to have palpitation in this strip. Now, before we go to the next slide, I will also emphasize that very important when you order a Holter, you need to know whether you're able to, number one, catch the symptoms or not. So if the patient having palpitation almost every day, so a 24-hour Holter will probably have a high yield of getting a diagnosis. And if the patient on the Holter, let's say having a palpitation at 2 p.m., so you will scroll to 2 p.m. and look for any symptom rhythm correlation. If they feel palpitation but the sinus rhythm, then you know that the palpitation is not due to any rhythm abnormalities. Now, if the patient has a symptom like maybe once a week or twice in a week, so a 24-hour Holter, probably a waste of time and money. You may want to do something a more prolonged one. Nowadays, we have all this patch rhythm, very convenient. You can patch it for 3 days, 5 days, or 1 week, or even 2 weeks. So this group of patient, if you think that it's worth it, then you put on a 1-week rhythm monitor. So let's say Wednesday, she got symptom at 5 p.m., then you go and zoom into 5 p.m. and look whether there's any problem at that point of time. Now, for those with even very infrequent symptoms, let's say once or twice a month, any Holter will not be beneficial, in my opinion, unless another reason why we order Holter, unless you want to look for any baseline abnormalities. What do I mean by that? For example, if you see a PVCs or you see a PACs, you want to quantify in a day whether there is how many times that this patient is having ectopic beats, how many times that the patient have ventricular ectopics or atrial ectopics, which may sort of give us some prognostic value in certain cases. All right, I think we can go on.
You need to consider a pacemaker. You have seen these, she comes running and saying, "What this? Do I need a pacemaker? What are your indications?"
Okay, to make it very simple, only 2 conditions warrant a pacemaker. Number one, you need to have bradycardia plus symptoms. And that is the class 1 indication for pacemaker. Bradycardia means that any bradycardia, you can have a sinus pause, sinus bradycardia. You can even have a Morbid 1 kind of block, but very symptomatic. It's correlated. Every time patient have a block, the patient faint. Number 2, if you're able to locate the block is at infranodal level, means that beyond AV node. Now, this is a bit more difficult, but a lot of us, when we look at a Holter, we are trying to look for any evidence of morbid type 2 block. Now, when we say morbid type 2 block, means that the PI interval is the same before a block. Unexpectedly, you will have a AV block. And most of the time, if we see this, sometimes patient may or may not have any symptom. We are very low threshold on implanting a pacemaker, because once they have a block at a lower level and the AV node, there is, I would say that the junctional escape rhythm from the AV node may not even escape to the ventricle, and a lot of time they have a standstill and faint before they have a ventricular escape rhythm coming out. So these are the high risk group. These two conditions, again, bradycardia plus symptoms, or number two, you're able to identify that this patient has a high degree AV block, at least morbid 2 kind of AV block.
These pauses, you have sinus pauses. It's the maximum length when you consider pacemaker. Patient has some doesn't have symptoms, but do a Holter and you find it's got a long pause.
Very interesting and controversial statement. Even in the guideline, it keep on changing. Previously, most of us know that if you have a sinus pause of more than 6 seconds when you sleep, or in awake you have more than 3 seconds, then there's a consideration of pacemaker, especially patient is symptomatic. So the keyword is still symptom plus bradycardia. And then the recent guideline, they remove all the how many seconds, because we know that it's very, very subjective. In general, I would say that healthy sinus node would not pause for more than 3 seconds when you're awake, and usually won't pause more than 6 seconds when you're asleep. So these are the things that you need to consider, and especially if patient is asymptomatic. I have patient that pause for 3-4 seconds, no symptoms. I'll keep watching them, advise them if you have symptom of giddiness, if you have fainting episode, then perhaps you need to implant a pacemaker. And these patients sometimes have been followed for 5 years, 6 years, 7 years. They still don't require a pacemaker yet.
Sorry. Okay. Or people have smart watches now. The patient comes and tells you his watch shows the heart rate is 38 right, or even AF. How do you respond?
This is what I call a new generation kind of symptoms. You don't see this kind of symptoms 5 to 10 years ago. A lot of patients knocking on my clinic door now, saying that, hey, my watch tells me that I have a very low heart rate. But these guys are all very fit. And I even wear a smartwatch myself. When I wake up in the morning, the alert, my heart rate is 40 beats per minute. So I know that these are very common physiological bradycardia, sinus bradycardia, especially when you sleep. So especially at night when you're sleeping, a low heart rate down to 40, probably not worrying. Number two, why the heart rate sometimes is low is because of the presence of sometimes ectopic beats. And this heart rate when you are sleeping, they detect what do you call it, PPG, the plasma plethysmography. So sometimes the PVC ectopic beats, they wouldn't detect it. So the heart rate is often cut like into half, especially you see those patients with ventricular bigeminy. ECG, you see that, but you look at the watches, it all shows the heart rate is like divided by 2. I will do an ECG, of course, to make sure there is no baseline abnormalities, and also then follow up the patient, reassure them. Again, if no symptoms, I will just say nothing much that we need to do at this point of time. Now, AF is very interesting. Most of the smart watches are actually designed to detect atrial fibrillation, if you notice that. Because atrial fibrillation has been a real burden and one of the most common arrhythmia in the world. The earlier phases of watches that detect AF comes from a company like Apple, the iWatch. then later have this live core cardiac monitoring. They all detect AF. But when you see patient have AF, the smartwatch only detect. We as a physician have to diagnose it. So what we do is every time when the watch trigger AF, I will ask the what do you call that, the patient to actually record an ECG. Some smartwatch able to record an ECG, and they come to me. I look at the ECG. They are usually either number one have PVC, because PVC they cause irregularity in the R interval. So the smartwatch thing is the AF. Number two, atrial topics, and of course number three, they really can be atrial fibrillation. So they are actually rather accurate. Now in group, there are very high risk of developing atrial fibrillation. For example, very elderly age group, more than let's say 65 years old, risk factor like diabetes, hypertension, especially those complain of palpitation. These are the very high risk group. I would personally do a Holter, maybe even though there's no symptom, I will just do a 1 week Holter just to look at why their watches tell me or her that she have atrial fibrillation. Perhaps they might really have atrial fibrillation. And recently, I think me and Dr. Jaya have a case also. I told you that you sent to me the patient have a watch detected AF. I monitored for a month. Then the watch is getting more frequent AF. I look at the rhythm strip, it's all PAC, atrial topics, and then I do a 7 days Holter. So able to capture that this patient indeed has atrial fibrillation.
On. I think the next case is co-schools.
Okay, so my case very simple. 60-year-old man came in just worried about high blood pressure, detected at home with an ambulatory machine, 180s, 90 in the clinic, resting state, heart rate 70 beats per minute, asymptomatic. Show me the blood test and also the urine test. He did outside, all normal. Urine FME, no proteinuria. So I just want to do a baseline ECG. And the reason I do, because I want to look for any evidence of left ventricular hypertrophy. So you know that in hypertension, we have to look for any evidence of target organ damage. So maybe Nazrul,
Yeah.
you can interpret the ECG for me.
Okay, well, so on first glance, this looks like a rather normal looking ECG. Right, as you can see, he's got P waves before every QRS complex, so that indicates his sinus rhythm. But if you look closely, first lead 3 and even EVF, you can see that the T wave is inverted. Yeah, and if you look at the lateral leads, V4, V5, and V6, you can see that there's full ST depressions and so flattening of the T waves. So I would say that this patient has got sinus rhythm, non-specific ST wave changes.
Yes, you're right. So all these are very non-specific ST abnormalities. So it includes all these segment abnormalities that doesn't fit into ischemic changes, doesn't fit into repolarization changes. So in general, any ST depression that is less than 0.5 mm, T inversion less than 1 mm, sometimes you see a T wave flattening, a bit of upsloping kind of ST depression. All these are probably non-specific ST wave abnormalities. Now, although most of the non-specific ST wave abnormalities doesn't carry any prognostic value or diagnostic value, but there are certain things that we need to be alert that they are finding in the study that shows that those abnormalities in hypertensive patients is significant because of their potential marker as suboptimal BP control. Like in this patient, maybe it's a marker of a suboptimal BP control. And in general, in the Framingham study, they noticed that those with all these ST segment abnormalities that are non-specific, in long term, they have higher risk of cardiovascular mortality. Now, also, there are certain studies that point that those with a non-ST segment abnormalities in otherwise normal ECG was associated with an increased risk of stroke. So I guess all these are markers of underlying uncontrolled risk factors.
I guess it is a step that you will probably want to assess cardiovascular risk and treat them. Okay, so what are you going to do then, Nazrul? This patient.
So this gentleman, just to recap, is 60 years old. He's coming very high blood pressure, 180 over 90. So that's considered stage 3 hypertension based on clinical practice guidelines. Now, as Cove mentioned, his blood tests were all normal, which is very important because, of course, that tells us what is this patient's risk for getting coronary artery disease. For instance, if he's got high cholesterol, high sugar levels as well. So for him, I would probably get firstly an echocardiogram done for him. Now, the reason for an echo is, of course, the ECG is to actually look at LVH, but the ECG is not very sensitive in picking up left ventricular hypertrophy. So an echo would actually tell us whether, in fact, the gentleman has got LVH. It may also give us a clue as to whether he's got any evidence of coronary artery disease. For instance, his ejection fraction is reduced. This is important because patients with left ventricular hypertrophy, they are at increased risk of getting cardiovascular events in the future. So this will also help us guide which type of antihypertensive we would like to choose for them, as well as the target blood pressure for them. So if a patient comes with left ventricular hypertrophy, you might want to consider putting them on an ARB or even an ACE inhibitor, and the blood pressure target will probably be a bit lower than normal, 130 over 80. Besides that, considering that his advanced age, I would also possibly consider doing further assessment to see whether he's got coronary artery disease, and I would definitely initiate him on medication as well as lifestyle changes.
So you initiated him on, sorry, cool.
Yeah, initiated combination therapy, perindopril and amlodipine, 5.
Combination.
So patients presenting with stage 2 hypertension and above, it is better for them to start them with a combination therapy rather than single drug therapy because number one, synergistic effect will help bring down the blood pressure much rapidly compared to a single drug. I completely agree with the voice of medication. So again, it depends on the patient's risk factor profile as well as his echo findings. So for this particular gentleman, considering that he's got a normal blood readings, and for instance, let's just say that his echo findings are normal, I would probably aim for blood pressure of less than 149. But if the echo shows evidence of LVH, I would probably aim for lower BP at 150.
About treadmill stress testing and echo, and you mentioned echo. Now, this is in the presence of abnormal resting ECG, as they have pointed out, with STT wave changes used for the treadmill stress test.
So, in the presence of baseline abnormal ECG, for instance, like in this case, or if they've got ECGs like a left bundle branch block, or even sometimes a right bundle branch block, doing normal treadmill test block very. So I would consider doing other forms of tests. We can either put in treadmill stress echocardiogram. So we actually looking at regional function at this before as well as after the stress test. The other thing that we can consider doing for him would probably a pulmonary CT, which I think should be test considering this risk.
Case. We are moving on to our fourth case, which I believe is a close case.
Yep. So I have this 51-year-old lady, again, asymptomatic, planned for laparotomy under general anesthesia. So routinely, sometimes they will send us abnormal ECG. So I mean, ECG is usually a prerequisite for them. So let's see what we have. Why they send this case to me? Let's see the ECG. So Nazrul, so what do you do? What is the ECG finding first?
Okay, so again, first thing, let's look at the rhythm. So if you look at the long lead, so you can clearly see waves. Sorry, it's actually a V1, yeah. You can actually see T waves, which suggests that this is a sinus rhythm ECG. if you look at the QRS, you can actually see that they're quite broad. There are about 3 boxes, which suggest they're about 120 seconds. If you also look at V1, you can see there's very dominant S wave. All these criteria suggest that this patient actually has got a left bundle branch block.
Right. So very important. I think the first, the earlier part one of a simple ECG presentation, some of you might remember Dr. Yap or Dr. Choi presenting a case of a right bundle branch block. Now, right bundle branch block sometimes can be a normal variant, but if you see a left bundle branch block, one should be very careful because it is often associated with significant heart disease, conduction system disease as a result of myocardial injury, strain, or hypertrophy. In certain cases, it can be also seen in patients without particular clinical disease. But for me, if I see a left bundle branch block, it has to be a rule out. Means that you have to make sure that the patient does not have any structural heart disease before you say that this is a normal variant. And we can see that in the premier study, very high percentage of them, even they claim that have asymptomatic left bundle branch block. The next 10 years, 50% of them develop cardiovascular mortality.
What's your next step of management? See her in your clinic, Nazrul. So it is, she's 51 years old, she's got a left bundle branch, and she's due to follow.
Okay, so always when setting a patient cardiovascular risk in a non-cardiac surgery setting, I think firstly it's important to look at the type of surgery that's going to be done. So for instance, if it's going to be a life-saving emergency surgery, I would probably tell the patient to go ahead with the operation without any further tests. But in view that this is actually an elective case and she has got an abnormal looking ECG, although she's asymptomatic, I would probably suggest to get a baseline echocardiogram done first to assess her LV function.
Okay, so everyone was done. Is it necessary to assess her coronary or in any way?
Yes, I think in this particular case, although she has got a normal ejection fraction, I would still consider getting her coronaries checked in view of a normal ECG. So the type of test that we can probably do for her would be again a stress echocardiogram or even a coronary CT. But probably in the setting of a patient going for surgery, I think a stress echocardiogram would probably be better because it gives us a prognostic valuation as well compared to a CT cardiac.
Well, as Ko mentioned earlier, the stress test will show how the heart rate responds to exercise. Am I correct, Ko?
Yeah. So we are assessing not only the coronaries, actually, we are trying to assessing the conduction system. Remember, in our heart, we have 3 main fiber going down to the ventricle. One is the right bundle, and the left bundle, they are left anterior fascicle and the left posterior fascicle. Imagine you have a complete left bundle branch block, so it means that 2 out of 3 fascicle has been blocked. So a very important thing that you need to assess the conduction system as well. So during the stress echo or dopamine stress echo, suddenly the AV block, and then you need to really consider, am I dealing with actually a conduction system abnormalities in this patient? Have to be careful. So because during a stress, especially after surgery, sometimes the patient may go into complete AV block. But again, I'm not too worried because patient is totally asymptomatic. The risk of developing this actually is quite low. But this is what we need to think in the back of our mind. So yeah, left bundle branch block itself have no specific treatment. So very important that we have to look for underlying disorder and treat the underlying disorder. Now, this is a case of a left bundle in the setting of elective setting. But where if the patient comes with an acute setting, don't say that no specific treatment. Because acute chest pain, patient fainted, those with already have heart failure symptom, this left bundle branch block is something very, very significant. And if you follow up long enough, patient with an asymptomatic left bundle branch block, a lot of them actually develop form of cardiomyopathy, usually a non-ischemic cardiomyopathy. And sometimes these patients have developed heart failure with left bundle branch block. You already treated with a standard heart failure therapy and the patient's symptoms doesn't improve, then a therapy can be considered, which is the cardiac resynchronization therapy with a pacemaker ICD system.
So we move on to our next case, which is case 5. I think it's case again.
Very interesting. So now this case is going to illustrate what I call a dynamic disease progression in the patient with a left bundle branch block. Now this patient came to me with a chest pain on exertion and shortness of breath and exertion for a month. No past medical history. So health screening 5 years back, the patient claimed everything is normal. So only the ECG had maybe abnormalities and doctors say that I'm born with it. So blood tests are unremarkable. Lipid slightly on the high side, but HbA1c normal. And again, Nazrul?
Right, so this ECG looks similar to the one that was presented before. So again, he's in sinus rhythm, broad TQRS. So again, it looks like a left bundle branch.
Yes, correct. So again, we have to emphasize from first case to second case. Once the patient has symptoms, then you have to really look very hard. Are we missing something else? And the echocardiogram is always the first non-invasive testing for a patient with a left bundle branch block. Now, this is not surprising to me. Expected to see something. So, but you can see that the septal area is akinetic. Do you agree, Nazrul?
Yeah, I agree.
Right. So this is something that we cannot ignore. In fact, I think I straight away tell her that she needs a coronary angiogram because this is a regional wall motion abnormalities. So maybe I'll answer this question for you.
Yeah, so I completely agree with Ko. Once you see a regional motion and abnormality with a left bundle branch block, I would definitely suggest for an angiogram.
Now, angiogram was done. If you look at the angiogram picture on the left, there's the pre-angioplasty coronary angiogram. Look at the initial segment that Dr. Jamala pointed. That is a proximal part of the LED and definitely significant narrowing. And after we stented, you can see that the difference of the coronary system. And this is done in view of angina, in view of akinetic segment in the ECG left bundle branch block. So the next slide also shows you another view of coronary. That's the part pointed. You can see that it's very eccentric plug. This view looks more significant. And after a stenting, you can see that the flow patency restored. Patient has actually no more symptoms. And surprisingly, within a month, I repeated echo just to see. The segment improved. You can see the left is prior to stenting, and the right, you see that the contraction. You can see how the muscle contracts and thicken. Unfortunately, the left bundle is the same. So a lot of times when you have a coronary artery disease, you know that it affects the left bundle and right bundle sometimes. And the disease sometimes can be due to fibrosis, due to ischemia, and maybe a infarct, has a subclinical infarct that has happened. So this conduction system, like left bundle, they are very sensitive. Once they are injured, they might not recover. So the ECG can be permanent.
You see, in patients with left bundle branch block, you'll tend to see a bit of dyskinesia, IBS. Maybe here.
You see a dysynchrony. We call it the intraventricular dysynchrony. But you shouldn't see a segment that doesn't thicken. So if a segment doesn't thicken, then like this is very perfect case. You can see that on the left side, it is not thickened. The muscle doesn't even contract, and the right side is very obviously improved.
So this is Nazrul's case. Share.
All right, sure. So this is an elderly gentleman, he's 77 years old. He has got an underlying history of hypertension, seismal AF, and he had suffered a stroke about 2 years ago. Since the stroke, he has actually been bedbound. He stays in a nursing home, and he actually came in with complaints of chest pain, which has been present for close to a week. Now, on further history, he's actually been on multiple medications. He's been on bisoprolol, valsartan, spironolactone, Lasix on a per need basis, as well as apixaban for the AF for stroke prevention. Now, just looking at the list of medicines, it would suggest that this patient most likely has got underlying heart failure. Yeah? So, on physical examination, he wasn't in overt fluid overload. His JVP was not raised. He had blood pressure of 101 over 70. His heart rate was 70 beats per minute, but it was irregular. His lungs were clear, and there was no murmurs heard. Right. So,
Question I would like to ask. This is often many GPs and many doctors can ask. This man is BP is low, 101. Are you worried or will you stop his bisoprolol and his valsartan not to drop the pressure?
Now, blood pressure is very, how to say, individualized. Now, a lot of elderly patient on medication, the blood pressure are like Nazrul say, you want to expect about 120, 130. But these are patients that has heart failure. All the medication actually heart failure medication. When Nazrul showed me all the list of medication. And these group of heart failure patient, the challenge is the blood pressure is always on the low side. Sometimes the systolic can be 90 to 100. Now, I'm usually not worried. And in fact, I would not usually stop the bisoprolol because you shouldn't stop beta blocker or ARB in patients stable on the medication for many years. This will actually worsen the heart failure. And most of the time, these blood pressure are quite stable. However, in the event that you think that the blood pressure is causing the chest discomfort, chest pain, you think there's an acute event happening, you can perhaps withhold just for that 1 or 2 days while you do further investigation. Like in this case, maybe I will hold one dose or 2 doses. I will do again investigation like ECG, echocardiogram, consider coronary assessment in this patient.
So basically, I wish to emphasize what Ko has said, that these are heart failure medications. So they were not given because of blood pressure. Because a lot of times the pharmacist will tell them, this is for your blood pressure. And patient will come running and say, well, should I take it? So no, it is for heart failure. Okay, so this was the ECG. So,
So this ECG again, this patient has chest pain, right? So we have to, again, when we order ECG, we have to really see what we are looking at. Any particular ST segment that is markedly raised? No, not really. But this is again left bundle branch block kind of pattern. In fact, it is very more abnormal than my 2 cases. You can see that the rhythm is irregular. Given your past medical history of AF, most likely this patient is in atrial fibrillation. Lead 2, 3 AVF, you can see that it is almost like a Q wave kind of thing. Yeah, a lot of left bundle, you still can see a bit of R wave, but this one Q wave. So this patient must have very poor ejection fraction, maybe from previous myocardial infarction or have a severe non-ischemic dilated cardiomyopathy.
so that bundle, atrial fibrillation. Further you want to know?
We always start with a non-invasive like blood test, maybe an echocardiogram. Blood test, what should I order? Maybe in the setting of chest pain, looking at this ECG, maybe I should order a biomarkers.
So we had a high sensitivity troponin T done, which was mildly elevated at 20. So the normal reading for this would be less than 14. Yeah. Otherwise, his other blood tests were perfectly fine. Okay? So
going back to sequence of HST is raised. But remember, as was mentioned earlier, this kid has been having chest pain for about a week. Huh?
Okay, so shortly the significant level, if it's very high, for example, more than 100, then that is really significant. Anything that below 50, it is moderately significant, I would say. But importantly, it's not a single number. If you remember our basic physiology, all these biomarkers is meant to be looking at the trend. Even in fact, the CKMB, you look at the trend. CKMB is the one that is going to raise first. CHOP-T going to raise like 4 hours later to a day. Then you're going to maintain there for 2 weeks. So I will need to monitor the CHOP-T again, perhaps the next day. Or I could also complement it with ordering another CKMB. As you said, Dr. Jamala, this is already almost a week. But sometimes the symptom tells you that the angina can be there for a week, but the point of infarct, we're still not too sure when is it. So perhaps patient have this morning point of infarct, within less than 4 hours, the CHOP-T just raised a bit. But if you do it tomorrow, then or maybe 6 hours later, then you can see the CHOP-T significantly raised above 100. Now, this trend of rising also very important to tell me from 14 to 100 within 6 hours is something very, very significant. If you repeat later on, it's still about 20, 14, and then probably not so significant.
Yeah, so it must be taken into context, as you always pointed out, case of symptoms, clinical condition, and yes, look at trend, the rise and fall. So sync reading, very difficult to interpret. Okay, so this was his echo. Nasrul, you want to tell us about this echo?
Yeah, so I think Kung was actually spot on in saying that this gentleman most likely has got a very poor ejection fraction. So sorry about the image, but if you can see, his LV function is somewhere between the range of 15 to 20%. The whole heart is not contracting well, so that's global hypokinesia. This all would suggest that this man most likely had some form of infarction in the past, and hence why he has been on all the heart failure medications. So, as Dr. Jai had previously mentioned, I think it's very, very important that we maintain those medications in this gentleman, help preserve his heart function, and not to stop them. Yeah. Anything else like that? No.
So our last case today is again Nazrul. Nazrul, take us your last patient.
Again, this is a very young, fit gentleman. He's 28 years old. He's very active in sports. He says he plays basketball at least 3 to 4 times a week. He does not smoke. But he says he's been feeling a little bit tired lately. And when poked further, he says that he usually does not have any trouble going up and down the stairs at work, but lately he felt a little bit breathless as he goes up and down the stairs. Initially, upon looking at him, I didn't think much of it because he looked very fit and very well. On physical examination, JVB was not raised. He had normal vital signs. However, we did notice that his heart rate was 80 beats per minute, but it was irregular. His lungs were clear and he did not have any abnormal movements. Yeah. So this was his ECG.
Okay, so now there's the two parts for this ECG. Number one is to recognize the very pronounced abnormalities there. You look at, let's say, for example, V1, the third beat of V1 is a very broad complex. Yeah, complex. Now, this broad complex comes prematurely. We call it a premature ventricular complexes or ectopics. So this patient has a single ectopic beat coming from the ventricle. Now, the second part of interpreting a patient with a PVC actually is to read in between the line, means that look at the underlying ECG, whether any abnormalities or not. Now, a lot of people just get too excited, hey, I got PVC, but actually the thing is you need to roughly find out the etiology, why this patient has a PVC. For example, some patients have PVC, but you look at the underlying rhythm, it's actually that infarct in the V2, V3, or inferior infarct. Some patient may have LVH. So this patient will be PVC. Like in this case, it's not entirely normal. V1 shows that there's a right bundle branch block pattern. And when you look at lead 2, 3 AVF, especially the 3 and AVF, there's a bit of subtle T wave inversion. lead 3 and AVF. And at the end of all this QRS complex, you might wondering why that is like a fragmented lesion there. So this tells us that this patient's underlying conduction system itself is not very healthy. Often it tells us there's some form of fibrosis in the heart. But of course, this ECG is not, again, ECG is not very specific, but it's very sensitive. So I will be a bit worried, especially Nazrul, you say that he's previously a very active sportsman.
Yeah.
And suddenly now he become very symptomatic. So I will investigate further.
What we do?
Again, the first and foremost thing I will do is echocardiogram, just to look for whether patient any structural heart abnormalities, and of course blood tests in a young patient will tell us, make sure patient have a normal thyroid function, electrolyte all must be normal.
So this was his echocardiogram. As you can see, so the picture on the left-hand side is the porch chamber view, and on the left is your parasternal long axis. So as you can see, the contraction of the heart is globally impaired. His LV function was estimated in the range of 30 to 35%. So essentially this would explain his symptoms of exertional breathlessness that he's been feeling for the past couple of weeks. Anything else like that?
Yep. Okay. Now, if you see a structural abnormality in heart, especially globally dilated, the first thing is to ask whether this patient has an ischemic form of cardiomyopathy or non-ischemic form of cardiomyopathy. For those who is very high risk, like elderly, diabetes, hypertension, sometimes straight away I will order a coronary angiogram. Like in young patient like this, probably a coronary CT angiogram is enough to see whether it is ischemic type or non-ischemic type. And if it's a non-ischemic type, then I will further find out why this young guy has a cardiomyopathy. So we need a tissue imaging. What do I mean by tissue imaging? It's a cardiac MRI imaging to find out the etiology. And then the third thing is, let's say it's a non-ischemic. There's a lot of non-ischemic, and PVC induced cardiomyopathy is actually one of it. So then I'll do a Holter. Now Holter in this case is to quantify the burden. Now, whenever you see a PVC, when you order a Holter, number one, of course, is to quantify the burden. Any burden that is more than 15% is considered significant. What do I mean by burden? Burden is abnormal beats against your total heartbeat. Means that in every day, most of us have about 100,000 beats. 22% means that you have about 22,000 ectopic beats. That's quite significant. Number two, you want to look for any short run of non-sustained VT. Now, short run of non-sustained VT in the setting of EF that is slow means it's dangerous. It's a red flag. Okay, you have to really be very alert and send for electrophysiology assessment. Number three, you want to look for, is there a multifocal PVC? Now the difference is, if you see a unifocal, most of the time you know that these PVC are idiopathic, means that they doesn't come from tissue problem. Now if you see multifocal, you really have to consider rare cases like arrhythmogenic right ventricular dysplasia. That's why sometimes in the baseline ECG you see a right bundle branch block, a bit of a fragmented QRS, we call it the epsilon wave. These are subtle things that we often look for. And also sometimes patients with myocarditis can have a multifocal PVC, patient with scoliosis, patient amyloidosis. These are very important to look for. Number one, again, burden. Number two, whether there's a presence of non-sustained VT or not. Number three, whether there's a multifocal PVC.
So,
I've answered that.
so that
This was his MRI finding. He had non-ischemic dilated cardiomyopathy, and his EF actually correlated with the ECMO, 30 to 35%. So what we did for him was we studied him on all of his empty failure treatment, Entresto, bisoprolol, dapagliflozin, and spironolactone. Initially, during the initial stages, we had done pro-BNP for him, and it ranged in the range of 1,500, and his symptoms had actually improved with medicine. He had come down to about 58. One clinic review, he was feeling much, much better at that time.
Is there a rule, if anything at all, about PVC ablation? Or when would you consider PVC ablation?
Good question. So this is a chicken and egg theory. If you think that the PVC is causing the cardiomyopathy, of course, the first step is to ablate the PVC. But if you think the heart failure is the one causing the PVC, then is to treat the heart failure first. Now, in this case, it's very difficult to know unless you follow up the patient. For example, scenario number one, I see a patient with a PVC, very high burden. EF is normal. And after 1-2 years, the EF dropped. Then this certainly I know that the PVC probably the one that triggered this patient to go into heart failure, and I will ablate the PVC. Number two, if the patient under your follow-up for heart failure, EF already 30%, you're optimizing the medication along the way. Suddenly you see, one day develop a lot of PVC. Now, this most likely is due to the underlying cardiomyopathy that causes the PVC. And you might want to consider to increase the beta blocker dose, because beta blocker tends to suppress PVC, and repeat again and see whether the PVC burden is high. So any PVC burden that is very high, empirically above 15%, in the patient with heart failure, PVC ablation certainly has a role as part of an adjunct therapy along with other heart failure medication. Because PVC itself, we know, can worsen the heart failure.
Thank you very much. So the simple quick messages, go through your take-home messages.
So I think these 7 cases we have illustrated is very important. You have to interpret, although the ECG can be simple, but the patient can be complex. You have to take in context with the clinical history and the cardiovascular risk. And many cardiovascular diseases are dynamic. So follow-up are essential part of treatment management. Even if you see an asymptomatic left bundle block, asymptomatic non-specific ST changes, if the patient has high CV risk, patient are symptomatic, you need to follow them up, not to tell them nothing will happen, you just see me 10 years later. No. And very important, always manage the underlying risk factor, hypertension, diabetes, the hyperlipidemia. And sometimes you might want to consider a non-invasive test, like I have illustrated, a treadmill stress test, treadmill stress echo, dopamine stress echo, echocardiogram, and sometimes Holter monitoring if you want to capture the diagnosis or you want to quantify any baseline abnormalities. Further imaging, it depends on clinical scenario. Like we illustrated earlier, coronary CT angiogram can be useful, and sometimes cardiac MRI, especially in this young patient with a dilated cardiomyopathy, you want to know the etiology of this patient. Invasive testing like coroangiogram and EP studies may be warranted in certain group of patients.
Thank you very much, everybody. I would like to pass it back to Dr. Alan Tay to take over.
Okay, thank you, Jia. Now, we've actually hit 3 p.m. So we've got time for just a few questions. Bring up the slide rule. See is giving trouble. This question we'll start at the bottom there. How low would the pulse rate have to be with symptoms before considering intervention? And what are considered significant symptoms? There's a third from the top.
Be with symptoms before considering for intervention. So what are you considering significant symptoms? So this is a pacemaker. Would you like to just retract?
Okay. So I will come again. very important, the pulse rate is just a number, but of course the number also have a value, like give us a guide. Now, if you have a significant bradycardia with symptoms, means that, example, the pulse rate, any awake pulse rate is less than 40 is considered significant. Because most of the time, even you have Rankin-Buck block, your pulse rate wouldn't be persistently below 40 beats per minute. And if you have sinus bradycardia, anything less than 40 is definitely abnormal. And symptoms are usually bradycardia symptoms, usually giddiness on exertion, or syncopal attack, or pre-syncopal attack. So these are very significant symptoms. Of course, if you have a brady and a syncope, able to document the symptom and rhythm co-relationship, pacemaker is definitely a warrant.
Okay, we'll move on to the next question. Case number 4, ECG shows deep Q wave, L2 and AVF. Does that signify only?
This is the case with the left bundle branch block. So who would you want to answer? So the Q wave in 3 and AVF in the presence of left bundle branch block.
Yes, of course. That's why when you see a left bundle branch block, sometimes you try to look for other abnormalities. So very sharp eyes. So a Q wave, a very deep Q wave in all these contiguous lead. Contiguous lead means that inferior lead, lateral lead, does significant old impact. So you can have patient with occluded right coronary artery, occluded left coronary artery. Left coronary artery supplies the bundle branch area. So that's why this patient may have a left bundle branch block, and then at the same time have a right coronary artery disease as well. So yes, this tells us that etiology might be ischemic cardiomyopathy.
Okay, we are really over short time, so maybe just one more question. Normal BP but multiple ventricular ectopics, you said beta blockers are used. Would they drop the BP, and if so, do we need to stop the medication?
So that means the use of beta blockers in patients with ectopics.
Langsung on answer this.
Yeah, so I think that the first line treatment for PVCs are, of course, most of them are not beta blockers, and there's definitely a risk of actually dropping the blood pressure. So what I usually tend to do is I start them in a very low dose, observe them and see how they feel. Now, if let's just say they are unable to tolerate the beta blockers due to blood pressure concerns, I think the other choice that we can give them is a non-dihydropiron group of calcium channel blockers like your verapamils and your diltiazem, which I think they don't really affect your blood pressure much. So I think you do have leeway and other choices of medicine to actually elevate the symptoms. But for instance, I think just like to ask this, if let's just say a patient is unable to tolerate medications and they're symptomatic, then PVC ablation, then the choice of treatment.
Yeah, correct. Right, assuming this question is asked in the context that this patient has already done investigation, and patient is the etiology is the idiopathic PVCs. So first of all, to control the PVCs, we know that especially in young patients, the BP is quite low. So a lot of times, even the very low dose of beta blocker, calcium channel blocker, they couldn't tolerate. And this group of patients, sometimes I have to resort to start an antiarrhythmic drug, usually the class 1C antiarrhythmic drug. And I think available in Malaysia is only Reconite at this moment. Propapanol are really off the market. In elderly patients, we might want to consider amiodarone. We don't like amiodarone because of a long-term side effect. So elderly, sometimes you can consider that. And of course, if none of this able to be tolerated, or patient preference to get rid of the symptom, especially every time they palpitate, they cannot work, they're afraid of going traveling, PVC ablation is definitely indicated.
Okay, I think we are past time, and more importantly, we have to stop soon because my laptop battery died. So this is the final bit. The CPD points are obtained by an attendance link. So not the QR code from the MMA app. The QR code here just takes you to the same link. docs.my/181123, which is today's date. So fill in the form, and then the admin will upload your points to MMA point. So the code and the link will not be valid for more than a couple of hours, the end of this session. So please scan now. Scan now, enter your so camera if it's an iPhone, and it should open the link. Error.
Mine, he don't know. Error in MMA.
No, don't scan with the MMA app. Scan with the QR code scanner, or just open the link in your browser, dops.my/181123. So you open your Chrome, Safari, or whatever in the browser there. Don't open Google search. Just open, put in the browser bar dops.my181123, and that will redirect to a office form. Then you enter your details there. First one is your email. Anybody got problems, you just post it in the chat. So sorry, we can't use the usual MMA QR code scanning because it's still disabled by the MMA. Yeah? Most important thing to enter correctly is your IC number. If you get it wrong, then the points don't get assigned to your IC. Very
Very much, everybody.
Thank you, everyone. So have a good weekend. Thank you, everybody, and good afternoon. We're going to end the stream now. Bye-bye.
Thanks, Alan.